I'm Ron Pearl, chair of the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University, and I've had the privilege of organizing this panel related to the future of anesthesiology. As I think back to when I finished anesthesia training 3 decades ago to today, we've certainly had advances in the safety and outcomes of anesthesia. But in reality, very little has changed. We more or less are using the same drugs I trained with, the same monitors, and the same organization of how we practice anesthesia. The concept of today's panel is this is about to change. In the next 5 years, we're really going to have a transformation, much of it being led by advances in data and computing. I've been fortunate to be able to recruit 4 outstanding speakers who are really experts in this field and who are responsible for many of these changes which will be coming, and we'll be discussing today topics such as information technology, decision support, artificial intelligence, robots, automated anesthesia delivery, etc. Each speaker will speak for about 20 minutes, which will leave us some time for questions at the end. Our first speaker is Dr. Warren Sandberg. He's professor and chair of anesthesiology at Vanderbilt University. He's also chief of staff for perioperative and critical care services there. He has clinical and research interests in the development and use of clinical informatics in anesthesiology. His goal is to leverage forward-thinking technologists and the capabilities of his institution to develop world-class anesthesia informatics and real-time decision support and apply those to precision perioperative medicine. And he'll be speaking on the topic of the use of information technology and decision support in anesthesiology. Warren.
Thank you, Ron. So I kept the title that Ron initially suggested to me, so it's different from what you see in the program. I have one disclosure. I basically had done some consulting for Edwards, but I won't talk about any of their technology. Here are the learning objectives, and I've got a lot of material, so I'm not going to read them to you. I celebrate the fact that you can read faster than I can talk. But I do want to focus a little bit, though, on the end, where we're going to talk about articulating the major obstacles that we still have to overcome to use electronic health records to improve anesthesia quality and safety. So the last part of the talk will focus a lot on the obstacles. So what good is a perioperative electronic health record? Everybody's made the move, mostly forced by legislation, but there are some good things that can come out of even a basic EHR implementation. For example, before there was MINS, there were rate-related EKG changes in the operating room. And there was a time when we told ourselves that these were no big deal. They were basically demand ischemia, and if you got the rate under control, everything would be fine. Now, that was the rumor, or that was the story, but the advent of an electronic health record allowed us to actually do these find a needle in the haystack searches and pull out the actual records of the few cases of rate-related ECG changes that happened among the thousands of cases that were documented in the record. And you could actually see what those looked like, and you could see what were the peri-event meta events, what led to them, and you could look at what people did after them. And what we discovered at the institution where this was done is that anesthesiologists did all kinds of things. One thing they didn't do was consistently capture the data that would allow the cardiologists to advise you on what to do. And the cardiologists were equally uninterested in following the patients up. And yet, in this little sample, 2 out of the 20 patients had actual coronary disease, and one of them had a myocardial infarction in the periop period. So one of the major limitations here, of course, is that this is a single center study, and what was true at the institution where this was done may or may not be true at your institution, and so these results are not generalizable. You will have to actually replicate this for yourself. There are some more general practice questions that an electronic health record can address, and these are 2 examples that were early publications from the MPOG group. I see Sachin in the room. I think Sachin can take credit for creating one of the first real multi-center perioperative outcomes databases and research project teams. And again, early days for MPOG were basically answering persistent questions about our practices that we had been fighting about for years. And we were able to resolve some of those. And now, having not worked our way through those questions, the MPOG group is now using electronic health record data to frame pragmatic trials and support them to answer fundamental questions prospectively going forward. And these, I think, are what electronic health records are going to allow us to do in anesthesiology. My favorite recent example, the saline versus balanced crystalloid butter battle that's been going on since I was an anesthesiologist. And there's been a pretty strong utterance that was supported by electronic health records and anesthesia that appeared in the February issues from a year ago of the New England Journal. And if you look in the middle authors here, right where you would expect to find them, there's anesthesia, okay? So anesthesia is inside these important studies. What did anesthesia do? Anesthesia did all the data management and all the randomization for a trial in which the primary outcome, Make 30, was one that we actually care about in health, with some secondary outcomes. And the study randomized 16,000 patients. Basically, if you fell through the door at Vanderbilt during the period of this study, you were in the trial. Because the two treatments were felt to be in equipoise, and we came up with an equitable assortment scheme that treated all patients the same, and simply varied the randomization of what month you were going to get either saline or LR. Our IRB actually allowed to do this without consent. And we used a decision shaping approach. We're presenting the ordering clinician the fluid that we wanted them to use as the default. We gave them the option with a few clicks to use a different fluid. And we were able to basically randomize every single patient who was admitted to 5 ICUs or through the ED to a non-ICU floor to one arm or the other. And here was the main result. Basically, balanced crystalloid was better, all right? And the major component of Make 30 that led to the biggest component was actually death, all right? So what the answer from this trial was that a few patients every year at Vanderbilt died because they got normal saline, and if we could actually drive this into routine practice and make everybody use balanced salt, we could actually save some lives. Now, the inside of this story is that we were not ready for this result. We were sure that there would be no difference. And so at the time that we got the data, we were switching from our homegrown electronic record system to Epic. And we did not build in the decision support into Epic to drive this into complete practice. And so that is an ongoing story today. The moral of the story here is that electronic health records can allow you to get the information you need to use to improve health for patients, but it requires constant application of effort at your institution by individual human beings to make your electronic health record address the problems at your institution. There was a concurrent study called the SALT-ED study, which looked at the difference between balanced crystalloid and saline in non-ICU patients admitted through the ED, fewer numbers of deaths, lower mortality rate, lower incidence of Make 30, but the difference was still preserved, and it went in the same direction. So here are the limitations of this study. Everybody knew that there was a study going on. Actually, most people were unaware that there was a study going on. But you could sort of notice that if you were an ordering clinician, some months you got prompted to order normal saline, and some months you got prompted to order LR. It was about as good an environmental study as you can come up with. So how now do we actually drive this result into practice? And I can't report on what VUMC is doing to drive the use of balanced crystalloids into practice because it's work in progress. But I can talk about some ways to use the electronic health record to manage performance of clinicians, well-intentioned but busy clinicians, into practice in other areas more dear to my heart, such as the operating room. So The goal is to get information to the clinician when they need it. Most of us are managing 20 or 30 things at a time when we're doing an operating room case. And if you'll just think about this morning, getting out of your hotel room, how many of you almost forgot your key? No hands are going, oh, there's one. Okay, thank you, Ruben. Okay, all right. Yeah, I have 2 keys, okay? I have a little checklist, and I've got one in my wallet, and I didn't forget my wallet. But imagine trying to manage 20 or 30 of those don't forget it tasks while there's actually other stuff going on in your operating room. Clinicians need better provision of information through the creation of transparency. EHRs don't provide transparency. They allow you to be able to search, but they don't actually present the information to you without you looking for it. We need information that's integrated and synchronized, and we really need, for things that are process measures that we shouldn't forget, something that I call automated process monitoring and process control, beyond decision support. Meaning, if you're about to forget to do something, or you did just forget to do something, we are going to make you attend to that. So this is an example of transparency. This is our command center. We're a level 1 trauma center. We run 60 operating rooms in our main OR suite. And the person right there, who's the AIC, the anesthesiologist in charge, can immediately see the status of every operating room, what's happening in there, okay? That is the most fundamental form of transparency. And we can actually bring this right into your hand. This is a screenshot of somebody's iPad, and if I'm running 4 rooms, I can see immediately what is going on in each of those rooms. Not perfect transparency, because this is not on the splash screen of my iPad, but at least it's closer. Talking about synchronization and fusion of data, we can talk about the OR checklist journey. How many people currently manage your hard stop timeout prior to incision using a piece of paper on the wall? Right, okay. So this was Vanderbilt when I arrived. In 2010, we did a wrong-sided craniotomy. The good news for the patient was that they had a lesion that crossed the midline, so, but it was a hit, okay? So we actually did something about this. So we developed what's an electronic flight board, and this is basically the entire team. I'm standing behind the drape as the circulating nurse clicks the answers to these questions, and the boxes are turning from red to green as we go down the checklist. And the trick here is we've built in a hard stop in our record-keeping system that will not allow the nurse to continue clinical documentation until those tick boxes have been ticked, all right? So that's an example of a hard stop, which is what comes after a nudge, okay? It's when the elephant stomps on you instead. So, and this is now done, and we've got the green bar, and we know who's in the room, and a few other pieces of information, and people are working. Now again, this application was developed in our homegrown electronic medical record environment, and like so many of you do, we made a big change to a vendor product. And I'm happy to say that we were actually able to build functionality into that product and actually help the vendor improve the functionality of their product. And we actually improved what we call the electronic flight board here. This is a piece of this is test data, so don't freak out that there's actually a name up there. And it continues to run to this day. Now, the inside of this story was we solved what for Vanderbilt was kind of a non-problem, because as it turns out, when we looked back into our data, we hadn't actually done a wrong surgery prior to that craniotomy for about 5 years. All right, and for the 5 years after we did this project, we also didn't do a wrong surgery. But Vanderbilt is an organization just like every other, and institutions across the country, to the best that you can estimate, do about 1 wrong surgery per 20,000 cases. It depends on how you set the definitions. And I'm sorry to report that Vanderbilt is like every other institution. It does happen. And when you read the details of these cases, they probably couldn't be caught by a timeout checklist. When you get the error rate down that low, the nature of the errors is such that they are truly one-offs. Now, let's talk about, after transparency, automated process monitoring and process control. This, I think, is where the real benefit can come. The requirements there are you need an integrator of information that is doing it without getting tired and without getting distracted. In the operating room, humans are the most commonly used integrators, okay? But your electronic health record is also an information integrator. You also need a process model. That is a description, a computable description of what should be happening, the workflow of events, all right? And you need sensors to feed that process model. So you're basically comparing what's happening to the patient to what should be happening to the patient. And you need data sources in addition to the sensors. So your health information system, PACS, and administrative data are the ones that you most commonly think of. You need triggers, which are business rules. What are you going to do when the process runs off track? And you need an enunciation pathway that is hard to ignore, all right? So mobile phones are a pretty good one. Most people carry their mobile phones and they respond to them. I actually miss pagers in this regard because it's really hard to ignore a pager. And pagers are a mild aversive stimulus. People don't like getting paged, and they actually learn to avoid the pages. So, can we actually use process monitoring and process control to influence medical outcomes? So I'm going to tell you a modest success story about glucose measurement at Vanderbilt. This solution that I'm describing happens completely automatically. There's no human input involved except to respond to the page. Now, Vanderbilt is a high-class medical center, yet if you're receiving insulin at Vanderbilt, when we started this project, there was a low probability that you would get at least one glucose check during surgery until surgery had lasted 8 or 9 hours. Over time, we were able to drive the completeness of glucose measurement hourly for patients receiving insulin up to nearly 100%, but you can see this was a long slog. And then we did get a nice result. This was a before and after study of the surgical site infection rate before and after the provision of alerts. And I'm happy to say that no matter how we tortured this data set, we could not make this difference go away. So this is called p-whacking. It's the opposite of p-hacking. So I'm happy to say that despite the critical flaw in the experimental design that kept us from claiming that this was causative, the association was hard to remove. And we were able to persuade the editors of Anesthesiology. And this was basically the career maker for me. This is what I've been working for the last 15 years. Not this problem, but the fact that we could show that we could do it. So I'm ready to retire. Now, this doesn't always work, all right? Whether you believe in the triple low phenomenon or not, at least in some institutions, there's an understanding that the triple low phenomenon impacts length of stay and mortality enough for that institution to go on a nudging path, just like we did for glucose measurement. And what they discovered was that clinicians largely ignored the alerts, and when they did something about it, nothing got better, okay? So we don't understand the triple low phenomenon, or how to manage it if it's real to improve outcomes. But this part about clinicians largely ignored the alerts is really kind of distressing. If your patient is in the can't take a joke range, they have a low BIS with no anesthetic requirement and they're hypotensive, most of us doctors would want to do something about that. So here are the limitations that we're facing. Latency, workflow design, and the fact that these are single institution results that are difficult to reproduce. AIMS and EHRs can run queries on a query interval, but if you're actually using an event that you manually document, and you document that late, then the time between when you did it and when the next query interval runs is called the latency. So it's impossible to do real-time management of clinical performance if you're using clinical documentation events. Workflow and ergonomics affect latency, and if you don't actually document something, then the latency is infinite. And similarly, if you're using a record-keeping system where you only access the data once at midnight, you don't have a decision support system. Workflow design is also a factor. If you decide, for example, that you want to get a page if your patient enters the PACU without PACU orders, and you set the trigger for that to check to see whether there are orders when the patient enters the PACU, you will interrupt the physician when they are going to do their next task. But if you build the order prompt upstream, then you can actually page the physician when it can help them. we are facing in the decision support world a problem of an added piece of complexity. Decision support systems deal well when the decision risk is low, they can handle important information, higher information complexity. When the decision risk is high, the information complexity has to be lower. And there's a frontier that we are pushing outward as we actually make these systems better. But in anesthesia, where seconds count, we've added the temporal axis, and so decision support systems will be challenged to move from relatively low function down near the vertex here, further outward. And this is, I think, the frontier that we are working on in AIMS and electronic health record decision support systems. Are we ready for this? I don't know. This is a PACU, lots of computers around it, and this flashlight that's been turned on to point at the ceiling is the signal that the PACU nurses use to declare that the patient is ready to be transported to the floor. This is modern world. Here's the biggie, okay? The HITECH challenge, HITECH was a piece of legislation that passed about 15 years ago, and it took the institutions that were performing down here in terms of their required level of performance up to here. It also shaved off many of the true innovators in healthcare informatics research, because the cost of implementing an electronic health record has been very large for a lot of institutions. And so there has been a stunning of centers as they get to the minimum level of required performance. But I think we're coming out of it. So here are the limitations again. I want to focus most on the non-transferability of single center studies. This is a deal breaker. It means that academic medical centers and academic anesthesia departments, who are the only ones who really are willing to commit the resources to solve these problems at their medical centers, actually have an advantage if we are willing to, on a single department by department level, make this investment. And that's my closing message. Thank you.